Kia ora everyone, welcome to this Goodfellow Unit Webinar on a practical and successful approach to the adolescent with dysmenorrhea and pelvic pain. This webinar is kindly supported by Mercy Ascot. I'm Dr. Helen Fulcher, and it is my pleasure to introduce our speaker tonight, Dr. Fiona Connell, a gynaecologist and advanced laparoscopic surgeon. Fiona introduced advanced laparoscopic surgery to Waitemata District Health Board and is the clinical lead of the period pain and endometriosis service there. She is also a board member of Endometriosis New Zealand and has a drive for the early recognition and management of period pain and endometriosis, allowing women to live their fullest lives. Welcome, Fiona.
Thanks,
I'm going to hand over to you now to start the session off with this awesome talk I know you have in line for us.
Firstly, thank you so much for being interested in this topic, everyone, and for dialing in. That's awesome. And we had a little bit of back and forth regarding what would be useful for people. And this topic was selected because this group of patients are really vulnerable. They're young, they're just learning about life. And we know that internationally, there's a major delay in presentation to the time of getting specialist treatment and diagnosis. And in the context of being post-pandemic and all of the service issues that we've got associated with that, they're even more vulnerable than they were in the first instance. And in my line of work, I see a lot of people with period pain who end up diagnosed with endometriosis or not endometriosis. And there's so much information that these women and young women are really after, and so much of it can be given in primary care level. And so I think being able to do a lot of the educational stuff that we tend to do at the specialist level in primary care, particularly at this point in the world's history, is super important. Are you seeing my screen okay there, Helen? Is it working?
Yes, it's all good.
Awesome. Also, I really want to apologize. I'm recovering from COVID myself, so I do have a pesky cough, which hopefully won't interrupt the talk too much. So the objectives that I really want to work towards tonight are the very, very important key concept of the fact that girls and young women and women who come to us with period pain or pelvic pain that's less specific, excuse me, that pain is almost always multifactorial. We have this tendency to just think endometriosis quite a lot of the time, and that's really supported by a whole lot of excellent awareness in the media at the moment. But focusing on that one thing is not always helpful, and that's my key message tonight. I'd really love it if we could set this group of patients up to be able to reach their full potential. And I think the bang for buck in getting success in these kinds of interactions is massive when these girls are really young. So what we want to be able to do is give them really good explanations about what's happening to their bodies, give them an excellent immediate management plan, and also give them an idea of what to expect in the medium and long term, and have an idea ourselves, of course. And also at the very end, I'll give you some good resources to support patient self-management. So why have we picked out adolescents as a separate group to talk about? The reason is because these patients are dealing with a whole lot of stuff that is specific to them. You've got the hormonal turmoil of puberty, which is massive and has a huge impact on processing and emotions. They're just getting to grips with educational pressures. They're starting to be assessed and judged and have to sit exams. They hit intermediate and high school, and all of a sudden friend politics become massively amped up from primary school. They're dealing with identity and sexuality, and over time, more and more of them will have an experience that's traumatic at some point, which is hugely important in gynecology. And there's social media playing with them as well. They are never able to get away from constant messaging. There's cyberbullying, which can be to an extraordinary level, and again, really, really hard to get away from. And they're dealing with the pandemic, crazy polarized stuff in the world, war in Ukraine, Black Lives Matter, all of the violence that goes along with that. And again, all of these messages are coming at them all the time. And awareness of climate change and nebulous fears about the future. And then on top of that, a huge chunk of them, and we'll talk about the statistics in a moment, are dealing with a new phenomenon in their lives, which are these monthly episodes of bleeding, which can be incredibly painful, can be associated with massive emotional lability, and it's quite a lot. Excuse me. With all of this media stuff, they're faced with messages all the time. And this is fantastic from the perspective of increasing awareness. But some of the messages that I've been exposed to myself are things which have great intentions, but can be perceived in quite a terrifying way if you're a young woman and you're grappling with this problem. So a really common message out there is no cure for endometriosis. And of course, everybody thinks they've got endo when they have period pain because they're online Googling period pain, and that's what they get. It's a debilitating chronic condition, which is not particularly hopeful. And then there's a whole lot of stuff in the media, which you're probably aware of, in newspapers. And again, this is great for awareness, but it's people who have had really difficult times usually. People have lost their fertility, not done as well in their education as they would have hoped to because of their pain, have had to drop out of sports, and have lost jobs and lost relationships as well. Yeah, it's not an easy thing to be faced with if you're just starting to have painful periods and you're looking forward at how you think your life might be. And this is in the context of a real rise in anxiety, which is documented. With all of these images of what people are supposed to look like and this heavily curated expectation of what life should be. It's not surprising, and I'm drawing a link here which hasn't been proven by research that I'm aware of, but I'm sure it will be, that nearly 1 in 3 of all adolescents, and this is way back in 2012, between the age of 13 to 18 will experience an anxiety disorder. And between 2007 and 2012, anxiety disorders went up by 20%. And this is the National Institute of Health in the US. And so I'm really interested to know what happened after 2020 and what is it that our girls are dealing with. So our job as often the first medical professional, well, I'm thinking of you, not me, as GPs, in our minds is to be really aware of the potential differential diagnoses, be aware of recommended treatment guidelines, and give medications to improve symptoms. But the most important thing is to keep in mind why we're doing this. And the reason we're doing this is to lay the foundations for really good health for these girls and young women, I should say, and help them to reach their full potential. Because there's no doubt that if you have an occurrence every month that is difficult and that continues for years and years, the problems snowball and quality of life and potential does suffer. So I've mentioned the kind of doctor's perspective on what our job is, which is the kind of A plus B equals C, give a treatment plan situation. And I was really interested in what it is women are actually expecting from their interaction with us. And this is at the time when I was setting up services at WDHB. And I came across this, what I thought was really interesting study, and I really liked it because it did include New Zealand data. And this was published in the Journal of Psychosomatic Obs and Gynae. And so they use qualitative research to look at what it is that patients want out of a gynae appointment. They looked at 189 women. They actually reviewed 7 qualitative studies, sorry. And all of the studies were aimed to gain a deeper understanding of a patient's experience with chronic pelvic pain. And what I found, excuse me, What I found was really interesting was in all of the studies, the strongest theme was they wish to receive an explanation for why they feel pain. It's not that at the top they want to be given a medication to make it go away. They're actually seeking to understand why. A really strong theme was also legitimization of their pain. They don't want to feel like, oh, it's in your head. And that's feedback that I hear about, they've felt that their pain may have been dismissed or normalized a bit too much. They want to have personalized care that is appropriate to their stage of life and what they can achieve at that time. And they're also seeking reassurance. So if you compare that to where our minds are, there could be a little bit of a mismatch. And that may be part of why we may find these consultations challenging at times. So I'd like to just cover some key concepts in this slide. When it comes to period pain and endometriosis, what are the guts of what we're actually really talking about? And we'll cover some studies regarding incidence and prevalence of period pain and endo in a moment. But you have a young girl who has significant period pain every single month, which is a peripheral stimulus. It's a real pain. It's sometimes endo, but it's often not. In response to that pain, they develop protective muscle spasm in the pelvic floor muscles, which in themselves will cause pain, as tight muscles will. Over time, with repetitive pain over long periods, people do become centrally sensitized, and then small stimulus will create quite a large pain signal. And people are more or less predisposed to this depending on their genetic makeup, and some people are really susceptible. Over time, the more pain you're in and the longer it goes for, as we all know, the psychosocial effects really get into the mix. And you can think of this as a kind of sequential thing, and it takes shorter or longer for different people. And what we really would like to do would be to draw this kind of line here and prevent progression to all of these additional things. And this is where our role is as GP and gynecologist. I'm also in here as well. This stuff is pretty simple. If you've got pain and it's confined to the period, it's simple and manageable, and you can get really good effect with good management. As you get into more complex stuff on the right-hand side of the screen, it does become more complex to different degrees, and it can take quite a lot of picking apart. And this is where care really needs to be multidisciplinary. You need a good team of people around you to help. And massive bang for buck with a physiotherapist to address pelvic floor spasm. I call it spasm. In the literature now, that's not the word we use, but when I talk to patients, I call it that because it means something to them and they can understand it. Pain specialists and psychologists and psychiatrists can be incredibly helpful. This is complex in this area. If we can stop it here, so much the better. Now, a lot of patients feel like when they see somebody, their periods are normalized. And I was really interested because we do know a lot of data about incidence and prevalence of endo, incidence and prevalence of pain. But when you have a patient who comes and sees you with pain, what does that actually mean in life terms? And I liked the study because it gave me data that I thought was really useful to put the patient into perspective. And also to be able to give this information to patients can be really reassuring as well. So this was done in a single high school in a large city in Turkey. And I think it's transferable enough to us for this purpose. They managed to get data from 879 girls who were getting periods, which I think is a reasonable response. 92% of them reported dysmenorrhea. And this table on the right-hand side tells you how severe it is. Some of them are mild, but most of them actually report moderate and severe period pain. 52% use analgesics for the period pain. And for those people who take analgesia, 70% get a good to moderate response, which is great. So semantically speaking, you can call dysmenorrhea normal because 92% of people have it. But that's really not the message we want to be giving these girls. If they are taking analgesia or they're taking hormones and they still have pain, that means they're at a lesser level of productiveness than they should be. If that is the situation they're in, then I think it's really important that we tell them verbally that that's really significant and we're going to aim for a bit better than that. 62% of them pass clots. This is really important to me, and we'll talk about that in a moment. 32% will have absenteeism because of pain or they're heavy bleeding. Excuse me. And this stuff I find really, really significant as well. 59% become nervous or problematic. I think this is a language thing, have problems during their period. 52% want to disappear during their period. 51% feel suffocated and cannot cope in their period. And yet only 12% will see a GP and 17% will see a specialist. I don't know what those numbers would be in New Zealand, but yeah, I think that's numbers to keep in the back of your mind. So given so many teenagers actually have period pain, how do we frame that up from a medical point of view in terms of minimizing risk to the patient and making sure that we catch things in time? So just to run through some of the numbers of how common we think endo would be in this particular group. The WHO quote 10% on their website, but that's for the general population. I recently looked into this a little bit further for ENDS, Endometriosis New Zealand, and found in 2019 meta-analysis, again of the general population, not adolescents, published in 2021. And what they found was the prevalence is probably more like 1 to 5%. So it may be that that 10% number is based on older data and it's perhaps not that accurate. Excuse me. This paper here reviewed laparoscopically proven endometriosis in adolescence itself. So this is more relevant to our discussion tonight. And they found a range of 19% to 73% with proven endometriosis. It's a massive range, right? So how do we frame that out? There's a bunch of things that affect this. There will be a whole lot of confounding factors to do with referral. So in the group where there's 73% prevalence, is it that nobody gets referred unless they're absolutely on the verge of expiring? So all of them have got endo. The 19%, that was quite an old study. So is that a diagnostic thing? Were they missing stuff? Were they missing the more subtle lesions? There's a bunch of factors over the decades that would impact on recognition of endo, and also decision for performing surgery. So there is a huge variation in terms of whether teenagers will be offered surgery or whether it will be withheld until they're older, which obviously is going to impact how much endo you find in that group of patients. So if you're only giving it to people who are performing surgery for people who are really debilitated, then you're much more likely to find endo as well. So looking at those papers and picking out the ones that are probably a bit more close to us in terms of time and transferable in terms of the kind of hospital setup. The number that I pick, is about 50%. So when I'm counseling somebody with period pain, I say, if you've tried hormones and really good pain relief and you still have pain, then I would put your likelihood of having endo at probably about 50%. I would also factor in their family history and other risk factors. So in that group of girls who do have endometriosis, is it going to be bad endo or is it going to be negligible stuff that you can kind of ignore? So this is the same review, and sorry about this slide, it's really busy, but I could think of no cleaner way to show it to you. But they go through all the different studies that they looked at, and you can see they date back to 1980. And I've highlighted the more recent papers down the bottom. And what they've got here is the number of patients that they looked at in each study. Decent numbers for some of them, low numbers for others. Age range, wide range, but yeah, they're teenagers or young women. And then it goes through which staging that they used. And stage 1, the least severe, to stage 4, the most severe. And I've highlighted stage 3 and 4. This is when you've got endometriomas, bad adhesions, and it's really significant endo. And these are the more recent studies here. And you can see the numbers are much greater of the stage 3 and 4 as time goes on. So yeah, if teenagers have got endo, it can be bad and really significant. And that kind of endo can have a big impact on their fertility. So you don't want to miss it. And there are many guidelines. There's a New Zealand guideline, there's an Australian guideline. The guideline I've decided to present to you is the ESHRA guideline. This is the European Society for Human Reproduction and Endocrinology, I think. Don't quote me on that. The reason I've chosen this is not because it's better, but because it has a specific section where they look at adolescent management. So this was published in 2022, so also very recent and excellent, and they give a really good breakdown of the papers that they've looked at. So I won't teach you to suck eggs because all of you know this, but we'll just run through it really quickly for completeness. So consider endometriosis if there's cyclical absence from school, or they require oral contraceptives or hormones for dysmenorrhea. The history that suggests endometriosis would be cyclical, chronic, or acyclical pelvic pain, so any pelvic pain, particularly if it's combined with nausea, dysmenorrhea, dyschezia, dysuria, and dyspareunia. Risk factors to look out for: positive family history. I've seen it quoted that you're 7 times more likely to have endo if you've got a close family member with endometriosis. Excuse me. Obstructive genital malformation, so your Müllerian abnormalities. And that's related to the theory of retrograde menstruation causing endometriosis implantation. Early menarche or short menstrual cycle. They recommend that you consider and discuss vaginal examination. And in New Zealand, there's an estimate that 60% of our teens are actually sexually active. So you could actually examine most of them if they were open to that idea. And if you're open to that idea. Important job at this stage is to pick out stage 3 to 4 disease. And the simplest and most effective way to do that is simply request an ultrasound scan. And the best kind of ultrasound scan would be a transvaginal scan. If that's not possible, MRI or transabdominal scan. In the guideline, they talk about transperineal or transrectal scan. That's not really a thing in my practice, and I don't know many people who request that. It's probably more of a thing in Europe. But consider those modes of imaging if transvaginal scan's not appropriate. And then consider laparoscopy if your imaging is negative and medical treatments with good nonsteroidals and or hormonal contraceptives are inadequate. That's a lot of girls if they were actually coming to seek help for their period pain. Now, the quality of this blown up is not as good, so hopefully you can see this. When you are doing a vaginal exam for a teenager, of course, we're looking for what the uterus feels like, adnexy, masses, tenderness, all of that kind of stuff. And also theoretically trying to feel for nodules suggested of deeply infiltrating endometriosis. Endo has to be seriously bad to be able to pick it up on a standard examination. So sure, we have to do it and it's important to do it. But what I think is really important as well is that at equal excuse me, level of importance is to examine the pelvic floor muscles. So we've mentioned the pelvic floor spasm. I'll talk about that a little bit more in a moment. But when you examine, just using a single digit, if you sweep down on this one, examining the obturator internus, you sweep in the obturator foramen, and at the same time, what you need to do is ask the patient who's in frog leg position to push against your left hand, which is against the outside aspect of their knee. So they abduct against your hand to engage the obturator internus muscle, and you push on that. And really often it'll be really painful, and doing that will replicate some components of their pain. The other thing to do is sweep in this area here to examine levator ani. That can be tender. It's not as big of a thing as the obturator internus. But this is how to assess the pelvic floor muscles. And it's really helpful because if you do that and you can tell them what you're doing and what you're touching, and they can appreciate that that's what's causing the pain, it really helps with engagement, with management of that problem. So what does ESHRA say about medical treatment? Excuse me. So for severe dysmenorrhea and or endo-associated pain, first line, as we all know, combined pills or progestogens. In the New Zealand guidelines, there's a heavy recommendation for progestogens. In the Australian guideline and ESHRA, they're okay with combined. And the suggestion is oral or by IUCD, Mirena or JDS. The reason is they're effective and safe. Compliance is the biggest issue with the oral ones, and keeping in mind that depot may decrease bone mineral density. They say use non-steroidals, especially if hormones are not an option, and GnRH agonists to be prescribed by secondary or tertiary providers for up to 1 year, as long as you give add-back hormones. It's very rare that I would give GnRH. Excuse me. So that's the nuts and bolts of what we do as doctors. But in my opinion, our actual job is to explain to them why this pain is happening, explain the rationale for why we're giving them the medications we give so that they take it, because compliance is a challenge in this age group. And give confidence that we're going to believe and manage the symptoms, that we're going to keep endometriosis in mind, because very often that is a concern. And that whilst we're managing them, we are going to keep their future fertility in mind and do our best to protect it. And why is it so important to give the explanation, apart from the fact that that's what patients want? It's because it has a huge impact on pain levels. So on the left-hand side is a brain in pain, and it's super, super active based on functional MRI. After education, a whole lot of the activity decreases. The same group of researchers reviewed 13 RCTs looking into pain, neuroscience, education, and chronic musculoskeletal pain, which in this group of patients is often what they are. It's just not their back or whatever, it's their pelvic floor. And what they found is that neuroscience education is effective, significantly effective in reducing pain, improving patient knowledge of pain, but also improving function, lowering disability, reducing psychosocial factors, enhancing movement, and minimizing healthcare utilization. And that matches up with my experience as well, clinically speaking, and it makes sense. If your patient is worried that they're going to do stuff and cause harm to themselves, they're going to really lock down and become less active, and that's going to exacerbate a lot of the problems. Excuse me. And the brain is such an amazingly powerful organ. When it comes to severity of pain, your brain is going to decide a lot of that for you based on the messaging that they've got, their ideas about the pain, what they can do to alleviate the pain, what their body is doing at the time, fearful experiences, their memories. And there's a conference going inside, and all of these things interact, and it'll tell you whether something hurts or not and how bad that pain is. And our explanations will have a massive impact on what's processing inside these brains and the messages that our patients will actually experience. And where we want to get to is a point where once we've managed the situation and we know what we're dealing with, that there is an understanding that pain doesn't always equal physical harm, and they might be sore, but they are safe. And this is really simple, but I've been really struck by the fact that when I give this explanation to my patients and their mothers or their fathers, whoever's with them, they're really grateful, and they quite often will say, why didn't anybody tell me this before? And what I say to them when they've got dysmenorrhea is, I have a model, this guy here, and I'll physically show it to them so they can see it, because they might have learned biology, but a cartoon image isn't the same as seeing something and being able to appreciate it in real life. But I talk about the endometriosis layer, which is the lining here, and I explain how estrogen makes it grow so that you could get pregnant and you could have a pregnancy. And then progesterone comes along and matures the lining. And if you don't get pregnant, all the lining starts to break down as your progesterone levels drop. And the endometrium starts to shed, which is your period. And when it sheds, there's a whole lot of inflammation in this area here, and inflammation causes pain. The blood has to come through this little hole, which is quite poorly designed. And in teenagers, it can be like a little pinprick, really tiny. So to get the blood out, your muscles in your uterus will contract. And remember that they're really inflamed, so contraction hurts, and contractions are like labor pain. And sometimes you're having to squeeze clots out through a little tiny hole. So can you imagine how sore that would be? And they're like, oh yeah, totally. And if that blood can't easily come out through this little hole, you've got these big holes here, and the blood will track out and sit in your pelvis. And that's really common. 90% of people will have this. We call it retrograde menstruation. But the lining of your pelvis has got all these nerve endings, and it'll think that your body's bleeding to death. So you get even more pain signals. And once they've got that concept, their anxiety levels really drop, because they can picture that's happening and they know that they're safe, but this is a process that's going on. And I think this causes the bulk of dysmenorrhea, whether or not they've got endo as well. And keep in mind, in puberty, the uterus is a really different shape. The cervix is even smaller. There's a much bigger surface area to volume ratio. So you've got a lot of blood loss, but not much space for it to go to. And this is not proven by science. This is just by first principles. I can imagine why there would be more retrograde menstruation in this age group. The next thing that I explain to patients is that your body's response to pain is really natural, and it's a normal thing. If you break your arm or you put your back out, that the muscles around it will go into contraction, and that's to protect you so that that area can heal. And the same thing will happen in your pelvis. And you've got pelvic floor muscles, which are part of your core, and no kid knows what pelvic floor muscles are. So I show them my 3D model so they can imagine it. And they know what their core is because they're busy doing exercise and getting abs. And whenever you use your core muscles, you're using the pelvic floor. And those muscles stop you from leaking urine when your bladder's full. You have to poo through it. It keeps you from pooing when you shouldn't. And you also have sex through it. And if those muscles get really tight because of lots of pain, they will hurt as well. And then when they have to do work for you, they'll hurt even more. And they get that, and it makes sense. And they also understand the concept of spasm if you put your back out, and why if you go into spasm in your pelvic floor, your pain levels are going to shoot up and it could be excruciating. And how this might become a problem to the point where in between periods, they might get pain even though they don't have actual period pain. And it might feel a little bit the same, but a bit different. And it just lays the groundwork so that they understand that it's not all about endo, and there are things that they might need to do to be able to get out of that situation. And the other concept that I like to go into, depending on where they're at in their cascade of symptoms, is this cycle here. Because I think anxiety is massively important. And so the link between pelvic floor spasm and anxiety. And what I explain is pain is a sign of danger. What you're supposed to do is you're supposed to take your hand off the hot element or take your foot off the nail. And that pain means that your stress hormone levels go up in your body. And stress hormones make you feel really anxious, because anxiety does get exacerbated for these patients, for sure. Stress hormones are supposed to put you into fight or flight mode. So your muscles tighten so you can do stuff, and that can make your pain worse. That tightness in your pelvic floor can lead to hospital presentations, but your pain levels do increase, and it can all feed into itself if you don't know how to get yourself out of it. And I try and explain that anxiety is really appropriate, because it is actually normal if you're faced with this situation, but it can be really massively modified by the education that you get and how you respond to the pain. I think a really, really important thing to do, probably earlier in your consultation, is ask what they or their support person are most worried about, and actually address it openly and just deal with that. And the most common things that I get told when I ask this question, they're worried about endometriosis and they're worried about their fertility in the future. And those ones are big. But if you give them a good explanation and a plan for what you're going to do to address those things, there's a massive relaxation. And getting buy-in for compliance is super important in this age group. Executive functioning is still developing in the teens, and it's not easy when you're busy and you're learning a whole lot of stuff and you're tired and you'd rather be in bed until 11 o'clock in the morning to remember to take your medications. But if you explain why and how you need to take them, this can improve. So when they understand that a lot of the pain will be from the uterus and retrograde menstruation and related to the volume of blood and contractions, then they understand that the medications are to try and reduce the amount of blood. And if you have less clots and cramping and less retrograde menstruation, the pain levels might not go away, but they probably will drop. Excuse me. And for girls who are worried about the endo, they're worried about endo because they've got pain. If you give them hormones and the pain goes away, then you can assume that you're suppressing the problem, and that anxiety or the need for immediate surgery might kind of abate a little bit. There are groups of people with really atypical pain symptoms where that assumption about suppression might not really hold, but usually those ones are seeing a gynecologist. Another key concept, which is already covered by a lot of that other stuff, is the multifactorial concept. So we've covered uterine pain, peritoneal pain, whether it's from retrograde menstruation or from endometriosis. We've talked about muscle pain. Bowel is worth a mention. We know that IBS symptoms are really, really common in this group. We don't really understand why. We think it's a thing in itself. But if you've got this bowel sensitivity, and then you throw in hormonal fluctuations which alter the way the muscles function in your bowel, and then you add in stress hormones from pain, and then you add in a whole lot of inflammatory blood that the bowels are kind of swimming around in, potentially, you can appreciate why bowel symptoms will fluctuate when you've got your period, or when you're ovulating, or if you're super anxious. There's a whole lot of stuff to address. I haven't really dealt with it in this talk because it just will spin out. But it is worth a mention that if you have terrible bloating, heaps of cramping because your bowel motions are loose, or you're constipated, which are IBS symptoms, then that discomfort in your abdomen can kick off pelvic floor spasm, because you've got pain. You might be a bit sensitized, so that pain might be a bit more extreme. And the pelvic floor doesn't know where that pain's coming from, but it can respond by going into spasm and causing period pain because it feels like period pain. So that's why sometimes the symptoms that you get presented with are really confusing, and you need to spend a bit of time picking them out and putting them where they belong. Nerve pain, central sensitization, and psychological pain. That's the thing. Setting expectations is really important. So giving good strategies to optimize hormones, they only work if they're taken well. So you need to try and put as much responsibility for this and set that expectation that it is self-controlled. Give pelvic floor stretches, but warn that it can take weeks to notice any improvement. It's a real challenge for a functioning adult such as myself to do physio. I can manage it for about 2 weeks at a time. So it's hard for adolescents, right? We totally accept that. But if you could, the pelvic floor stretches, which you can find at the pelvic pain website, which I'll give you at the end, they're yoga poses. So a nice way to do it would be to join a yoga class or do yoga online to make it a bit more palatable. But also with these stretches, you can stretch till the cows come home. But if every month you're getting excruciating pain, you're going to find it hard to make progress. So you need to also reduce the pain triggers. Set the expectation that hormones do take a few months to really work. Expect side effects in the first few weeks, but they tend to settle and become much better over a few weeks if you can stick at it. Because chopping and changing hormones every few weeks or every 1 or 2 months really doesn't help. If the pain continues, these are safety points. If the pain continues, even with this really good management that you're going to, do by taking all your meds, then you will be referred to somebody else. Post-COVID, that's a much more difficult promise to keep. So apologies for that. And explain that the ultrasound is done so that we can pick out if you've got really severe endo. And if there are cysts or adhesions or a Müllerian abnormality, which increases the likelihood of endo, then you will refer on to a specialist. And also in your 15 minutes, don't forget to address underlying psychosocial factors. Refer to psychology or psychiatry as required. Ask about sexual trauma history. I ask if I'm going to talk about examining and if I can comfortably ask it, depending on who the support person is, and levels of nervousness and rapport in the first consult. I will ask about this. And it is amazing how many people will disclose for the first time or just disclose that this has happened. And it's really, really important. And I always frame it so that I explain, I'm going to be examining you and I wouldn't want to trigger you. So I do ask everybody this, but have you ever had any history of sexual trauma? Just to make it comfortable and give a reason as to why to ask. And if there has been, then I hadn't planned to talk about this, but it's probably worth a mention because we do know that chronic pelvic pain is more common in people with sexual trauma history. It's important to frame that up so that it makes sense and it becomes a thing that can be managed rather just, this has happened to me, I'm broken, I've got pain, which is not helpful. But if you've had a very negative and often painful experience in that area, those muscles will tighten in the same way that pelvic floor spasm happens. And that pain is part of your memory. And if you get period pain on top of that, then it's a much more pronounced link and it can be worsened for other people. And I think that really neutralizes it and makes it a much more mechanical thing that makes it easier to achieve engagement over linking it in, managing it, but also engagement with psychology or physio, which otherwise might be a little bit uncomfortable if you've had a very negative history. Also improving supports at home and school. And of course, this can't be done in 15 minutes. I'll often give 45 minutes to my new patients if they've got a really complex history. And even then I'm struggling to cover all of this. So I bring people back. So having said and done and addressed all of that stuff and explained all of that stuff, what is it that a gynecologist can offer? First and foremost, reinforcement of all the beautiful groundwork that you've laid. Optimizing hormones, because it is tricky to achieve improvement in periods sometimes for some people, because you've got to get the balance exactly right. And there's a whole bunch of people who have bad side effects, in which case Mirena or JDES can be a really helpful option, plus or minus laparoscopy. I tend to put in IUCDs under a general, because I'm not very keen to add to the pain that people have had in that area. And I think if you do it in clinic, it can cause a pelvic floor spasm. And if that hasn't been really well addressed ahead of time, you can end up in a situation where the cramping from the settling in period will kick off a whole lot of pelvic floor spasm. And it might end up in the patient wanting the IUCD taken out for that reason. So I do have a low threshold for doing that under general. According to ESHRA guidelines, from a gynecology point of view, consider laparoscopy if initial treatment is not adequate. But they say, keep in mind, symptom recurrence rates may be considerable, especially if you don't give post-operative hormones. And I'll give you some numbers around that in a moment. If there is surgery, it should be laparoscopy by an experienced surgeon, and if possible, complete removal of all present endometriosis should be performed. And consider post-operative treatment, as this may suppress recurrence of symptoms. So I think we've all had this experience where somebody's had a laparoscopy and outcomes may not be as great as we would have hoped. What does Cochrane have to say about this? When it comes to surgery, that laparoscopic treatment of endo is significantly better than diagnostic lap. So what they're saying is, rather than going in and having a look, seeing the endo and then continuing with hormones, see it and treat it at that same operation. Limitations of this review were that there was short follow-up, 6 months or 12 months. And few of the women in this study had severe endo. And they confirmed level B evidence that removing deeply infiltrative endo reduces pain and improves quality of life. But they recommend treatment being at a centre of expertise, which at this point in time we don't quite have yet in New Zealand. And so what this slide is about the different techniques in surgical treatment. And I explain it not because you guys need to do this or know the ins and outs of it, but this has been really quite big in social media, and there's been quite a lot of talk about ablation and excision. And at some time there was a really strong message that endo needs to be excised and ablation is no good, and that kind of got a hold. And then guidelines have come out where this emphasis hasn't been as strong, and people are confused. I think it's a really oversimplified conversation. The key thing is that you can't just say that, because not all endo is the same. You've got superficial stuff versus deep stuff. It depends where the stuff is to be able to ablate it. You need to burn it. If it's on a ureter, that's not a good idea. Depends on the size of the area affected. So if you've got 2 spots, great, burn, fine. But if you've got 50 spots over 5 centimeters, then burning it, yeah, sure, you could do that. Tricky. Removing it by excision a bit quicker. Yeah, so there's different techniques for what you find, is what I'm trying to say. The quality of retrospective evidence, which is the bulk of evidence around this, is a bit limited by how the stages of endo is reported in the literature. And it's really hard to pick apart, because within an operation, you might do a bit of ablation and a bit of excision, so it's hard to compare outcomes. There there are RCTs which have found that ablation is comparable to excision in terms of outcomes. And this is why there's been a bit of a backtrack from that message that all things must be excised. Because if you compare outcomes, you can do either and you can get similar outcomes. However, those RCTs are limited to superficial endo. Deeply infiltrated stuff, which is about 5 millimeters. And, so when it's invaded 5 millimeters below the peritoneum, is really hard to ablate because you'd have to burn for such a long time to destroy the tissue that you'd get massive thermal spread. Yeah, so RCTs are more about superficial endo. Now, in teenagers, in adolescents, it's more common to get superficial endo that looks like this. So we have in our minds this idea of brown endo and black endo. Endo can just look like this, really subtle stuff, which is quite hard to appreciate. You need to have seen and been exposed to quite a lot of endo to know that that's what that is and to know to treat it. And this is probably more classic of what we think when we think endo, this big kind of black spot. This is deeply infiltrative, and you can see all the kind of, well, my eye can see all the fibrosis and all the abnormality associated with that below. These things here are flame lesions. That's a different look of endometriosis. And yeah, if you try to ablate that, you'd have to kind of torch the whole pelvis for a while. This is what it looks like after it's been excised. And you can see where the rectum is here. After it's excised, the extent of the rectum is all around here. Yeah, so for this, ablation's no good. Excision is the thing. Same with this, you can see the ureter coming along here, kind of somewhere amongst this endo here. Not appropriate for ablation, but simply excised. And that's what it looks like here. And the ureter's running along comfortably there. And then stage 4 endo. So adhesions everywhere. You can see hemosiderin where the endometrium is ruptured, and that would cause a lot of pain. Scarring, kissing ovaries here, rectum underneath here. Inflammation. There will be microscopic endometriosis in these adhesions, I would guess. Yeah, so you can see how the studies are kind of limited because you might look at the outcomes, but without really clear descriptions of what you've found, it's hard to tease out what the outcomes actually mean. Does surgery actually help? Patient satisfaction and changes in pain scores after ablative laparoscopic surgery. This is just for stage 3 to 4 endometriosis and endometriotic cysts. Mean pain score coming along here. And so in these women with quite significant endometriosis, you do surgery, you treat it, and at 12 months, dysmenorrhea decreases from about 5.3 down to just above 4. So some improvement, but not amazing. Chronic non-menstrual pain, bigger improvement. And dyspareunia, big improvement. So you're getting pain scores below 3, which is really good effect. So it does kind of make you wonder what's improving the pain. With the dyspareunia in stage 3 to 4, I think it kind of makes sense because you've got big cysts and anatomical abnormalities that you're freeing up, and that makes them more comfortable. I would guess that dysmenorrhea around the time of periods, there'll be a lot of uterine pain going on. This is adolescent data looking at outcomes after complete laparoscopic excision of endo. So a prospective observational case series, 17 adolescents, and that after complete excision, dysmenorrhea, dyschezia, constipation, tenderness on exam, painful exercise, intestinal cramping, and bladder pain, they all decreased significantly. But at an average of 23 months, up to 66 months, 47% needed a repeat laparoscopy for persistent pain. When laparoscopy was repeated, there was no visually or histologically confirmed endometriosis at all. So it's a very small study, but it kind of matches with experience that we've all had, I would say. And this one's a New Zealand paper, a cohort study of 20 adolescents with stage 1 to 4 endometriosis, and they had excision of endo. 2 of them had ovarian cysts, and they had significantly improved pain symptoms and significantly improved quality of life post-op. 10% of these had a repeat lap because of pain within 2 years, and no endometriosis was found. So what this makes me question is, was the pain actually coming from the endometriosis, or was the bulk of it just coming from the uterus and was due to retrograde menstruation? And that pain has just continued following excision. And why does the pain get better for a while and then it comes back and gets worse when there's no endo there? Is it other factors in life? You know, they're becoming more active, getting stressed because of it, and pelvic pain gets worse? Could it be that when you do the laparoscopy, you usually dilate the cervix and then you get better outflow of the periods, reduction in retrograde menstruation, and then over time the cervix goes back to how it was and you're back to square one? So there's a bunch of questions around the surgery and what it actually helps with. And it's really careful to be clear on what to expect from your surgery and do really careful pre-op counselling with these girls so they don't get disappointed if that should happen. And also so that they're expecting that there will be further work to happen after the surgery. And what I'm aiming for with preoperative counselling is to gain really common ground on understanding the complexity of pain. And there is a chance for some girls that they'll have surgery and their pain will be ongoing, and some people it might even worsen for other factors. Agreement on limiting number of surgeries over the lifetime, and being clear on the aims of surgery. It is to know what's going on, to reduce pain triggers by removing inflammatory endo tissue, but that might not be the bulk of the reason for the pain. To allow directing future management by finding endo, sorting it out, and being able to park that problem. And having the ability to insert a IUCD to manage, well, a Mirena or JDS to manage uterine pain whilst they're asleep. And the other aim of laparoscopy for some people is to also reduce the anxiety around it, to be able to park it, to let it go, and to be able to focus on other stuff that might be more important. And if I have somebody where I don't strongly feel like there might be endo, but they're really fixated on knowing, then that's fair, because the severity of pain and risk factors aren't proportional to finding endo or the degree of endo. And 50-50, I think, for finding endo is reasonable numbers to offer surgery. I think the risks are still much lower than the potential benefits. So I think this is actually quite pertinent. And another aim is to optimize future fertility. So in these women who do develop pain again, the questions to ask are, is the pain exactly the same? If the answer is yes, and it's been years, then consider endometriosis recurrence and consider further surgery. If the pain is exactly the same and within a short time frame, then if the endo was appropriately treated, I kind of assume the bulk of the pain was not directly caused by the endo. And if the pain's not exactly the same, it's a different thing, then I work from a perspective of this is a new thing and I need to start from scratch and do really careful reassessment to decide what to do next. And what I'm focusing on then is uterine pain, minimizing bleeding with hormones, focusing on muscles, tapping into physiotherapy, considering bowel components of pain, maybe referral to gastro or dietitian. And if it's really significant pain and it's really impacting, then pain team support often, and psychological support, because chronic pain is depressing and anxiety provoking, and psychosocial factors need to be addressed. And the good news is, once you've done that first surgery, if the pain then comes back, you've got much better purchase for engagement in all of this extra stuff, which at the end of the day requires a lot more personal effort than somebody else doing surgery for you. What lifetime advice do I give people who do have endometriosis that I've treated? That whilst you might get symptoms that come back and are difficult, the actual recurrence over 5 years is somewhere in the region of maybe 10 to 30%, but that depends on multiple factors. And it's similar to the prevalence of endometriosis in adolescents, where it depends on the study. It's very hard to estimate the recurrence rate and do ethical studies. And push out repeat surgeries within that time frame if it's sensible. Rely on management of other causes of pain and trying to prevent flare-ups by managing IBS, pelvic floor, and stress levels. And repeat surgery is something to think about if you have increasing symptoms despite optimizing other factors, if you have radiological findings suggesting recurrence, or if they have fertility concerns. And so resources that are very helpful. And I've got pelvicpain.org.au in larger font, not because it's better than the others, but because I think it is more relevant to this age group. If you've got an adolescent presenting to you with painful periods for the first time, I think it's good to keep the focus wide. And pelvicpain.org.au has excellent information about multifactorial pain. So it goes into bowel, it goes into pelvic floor, it goes into chronic pain, and it also covers gynae stuff as well. And I think if endometriosis becomes a real thing and you're talking about surgery or you've diagnosed it, then EndoNZ is a good place, and also Endometriosis New Zealand. And then you can get more targeted, sorry, I'm a bit mouse happy, more targeted information about endo itself. And I've also put vaginismus because with the pelvic floor reactivity, that can become a major reason for superficial dyspareunia. And that's got some excellent information and explanation in it, and also some resources that can help people, particularly if they're not quite ready to front up and see a physio about that. And so I do recommend giving homework to the patients so they can cover things in their own time. And it's much better to give them good stuff rather than let them Google. And the final message would be that success comes with having the tools to overcome complexity for both us and for our patients. And it can be a really positive experience.
Thank you so much for that overview and for pushing through despite recovering with your cough. So we really appreciate that. What a great overview, and lots of really good resources there. And I think just in terms of what you put in at the end, but also just some of the explanations that we can use for our patients when we're talking to them. It's just really simple and a great way to present it. We don't necessarily have the models that you have, but being able to explain or draw something for our patients would be really useful. We've had quite a good number of questions come through, so we'll go through some of them depending on how you're surviving it with your cough. First of all, is it known whether the incidence of endometriosis over the last couple of decades has changed? Has it been increasing, the amount that we're diagnosing, or do you think that it's increasing or changing overall?
Yeah, that's $1 million question, isn't it? I think it's a combination of things. So from the 80s, laparoscopy's been introduced and has become a bigger thing. Mm. And endo's not easily diagnosed by open surgery unless it's severe, stage 3, stage 4. Like, it's really hard to see those tiny little lesions if you're doing laparotomy. So part of it is the technology. So yeah, sure, from the 80s, much more awareness and diagnosis. And then also, I think there's a real possibility that it is increasing in prevalence in real terms as well, because endometriosis causes subfertility. And so with the advent of fertility treatment, those genes are being passed on really, really well, which is great. But it makes sense that the prevalence will be increasing, because in the past, a lot of people with bad endo wouldn't have been able to reproduce. Yeah, so I think there's a combo.
And actually that leads quite nicely to, there's been a few questions around, you've mentioned a few times about protecting fertility or managing fertility in our management of endometriosis. And can you just explain how we are protecting people's fertility by what we do?
Yeah, so endo affects fertilities in different ways. There's an inflammatory component, which is toxic, and that decreases egg quality, and it's toxic to sperm. So if there's a lot of inflammation, then there will be decreased fertility. Once you get into stage 3, stage 4, you've also got that, but you've also got mechanical stuff coming into play. So you've got tubal damage, you've got endometriomas, which physically damage the ovaries. So what you don't want to do is to progress from stage 1 to stage 4, because there will be a bunch of patients who will progress. A bunch of people stay stable, and some superficial endo does get eaten up by your immune system and it can go away. But what you're hoping to do is prevent that progression to mechanical damage. And I think that a really good way to do that is to pick up people who may have endo young and manage it medically to suppress it, or to remove it surgically.
Yeah. And I think there's someone who has asked around a particular patient, a young female with a severe history of dysmenorrhea, and is currently being managed mainly with the use of Mirena, but she's still getting intermittent dysmenorrhea. She now wants to become pregnant, and what could be done to allow her to be fertile while managing her dysmenorrhea. And I guess that's, you were speaking to the other things you're using, so anti-inflammatories and therapy that is non-hormonal.
Yeah, so I have questions. So she's got the Mirena and she's still bleeding on the Mirena, and it's painful periods.
Yes.
So for me, hearing that story, I'm thinking she's had an effective trial of hormones, she still had pain. I want to lap her and see if she's got endometriosis. Because if she's got extra triggers of pain, then I would like to remove that and make sure that's optimal. And she wants to get pregnant, so I would like to optimize that as well, if she was open to it. But I would guess that there will still be a big component of uterine pain as well. And so I would anticipate that there would be some pain, even if there was endo and it was removed. So to kind of preempt that, and to let's assume that that's the case. She's had the lap, she's still got pain, she wants to get pregnant, and she can't have hormones. So I try and make the periods as light as possible, so there's less cramping with tranexamic acid and non-steroidals combined. And I explain to them how to take analgesia really well. And I talk about having to take 3 doses to get into the therapeutic threshold, and to start Panadol before they start bleeding to get the levels up, and then to add in the cyclic aprox, tranexamic acid and non-steroidals once you start bleeding to try and reduce it. And I would assess their pelvic floor and see if we could minimize the pelvic floor pain as well.
That's fantastic. So there's a few ways you're addressing it, as opposed to just, would you do a trial of fertility prior to trying to do a scope when you first saw her?
Well, you would take the Mirena out and see where her pain was, the pain level. And there's enough, like if somebody has had a trial of hormones and they've taken decent analgesia and they still have pain that's getting in the way of their ability to function, then that's enough indication to offer a laparoscopy in an ideal world. So it depends on the level of pain. If you take the Mirena out and the pain is worse, then you're doing the laparoscopy for the pain, not so much fertility. So that whole waiting for 12 months is really in the context of somebody who doesn't have symptoms that are getting in the way of their life.
Okay, there's a couple of questions around both exercise and nutrition and their impact on the inflammation that can be related to endometriosis. Can you comment around that? Do you know about the evidence?
Yeah, what was the first question? I kind of...
Exercise and nutrition. So both of them, there is some talk around the impact that they can have on the inflammation related to endometriosis.
I don't know if exercise affects inflammation, but it certainly has an impact on pain. So keeping active, great for your mental health, but the kind of activity needs to be appropriate to where you're at physically. So we talk a lot about graded exercise and avoiding the boom and bust cycle. So doing what your body can cope with without triggering a flare up of pelvic floor spasm, because pelvic floor muscles that have been kind of really tight are not strong, they're weak. So you run the risk of kicking off a flare up if you do too much. So gentle exercise, gradually increase it as able. And I always talk about doing stretches and really looking at after relaxation of the pelvic floor. I think there's scant evidence about diets actually reducing inflammation, but my interest in diet is really about IBS symptoms and figuring out whether there are triggers that are making those symptoms worse.
Yep. Okay. There's been a number of questions around anti-inflammatories, and I know that mefenamic acid is one of the ones that we're commonly asked to use but isn't funded. And is it that much better in terms of how we respond to it? Is it something worth self-paying for, or what would be your other anti-inflammatory of choice?
I kind of cycle through. So usually if I'm seeing somebody, they're already on a non-steroidal. And if it works, I leave them on it. If it doesn't, I change it. So I'm very simple when it comes to that. Yeah, I think it's more, it's probably more a question for you guys, because you're the first people who, like, I very rarely am starting it. But, you know, the one that I just give ibuprofen.
Yep. Okay.
Yeah.
So there's no clear evidence that one is above the other in terms of its effect. Just individual.
Not that I'm aware of, but I haven't looked into that because it's not so relevant to me.
Yeah. At what age can you start using hormones or tranexamic acid? Is there a cutoff that you sort of sit nicely with, or is it individual again for the patient?
Individual.
Yeah. And what dose do you use for your tranexamic acid? How do you prescribe it?
1 gram, 4 times a day, which is a nightmare particularly for teenagers. Like, who knows what 4 times a day is? But you titrate it. So I prescribe it as 4 times a day, so they get plenty of tablets. And I say to take it for up to 5 consecutive days. But then I say, hey, why don't you just take it with your non-steroidals so you don't forget? But know that if it's not quite enough, you can take an extra tablet. Yeah.
Yep. Perfect. Pelvic floor stretches, are these the same as our sort of well-known pelvic floor exercises, or are they quite different?
They're the opposite. Complete opposite effect. So if you go to the pelvicpain.org.au website and you look at stabbing pain, there is a PDF that you can print out, and that has got instructions for the stretches, and a lot of them are yoga poses, and it's quite amazing. Like, it's really effective for a big bunch of people.
And there's a question around you've mentioned limiting the number of surgeries in a lifetime for someone. Why is that important?
So what I have in mind when I say that is sometimes I'll see somebody who has had 17 laparoscopies by the time they're in their late 20s. Yeah. If your aim is to diagnose endometriosis and treat it, and the recurrence rate over 5 years is only 10 to 30%, then I don't feel like I can't quite, reconcile the need for all those surgeries.
Yeah.
So you want to do a good surgery, be really effective with your treatment, and then eke it out as long as possible with too many surgeries, with each surgery, you run the risk of post-surgical adhesions.
Yeah.
Particularly if you get a post-operative infection, which is rare but possible. So there's all those risks of increasing adhesions. But in women who have had a whole lot of pain, you're also sensitizing them. So each time you do an operation, that's another pain load. And if you're fiddling around in the pelvis and doing stuff that's in that area, and you only want to be doing that and running the risk of central sensitive, or, you know, ramping things up, if there's a good reason to do it. Yeah. Plus each surgery has its own risks.
That's right. Yeah. Look, I know there's been lots of questions and we've run out of time, and I desperately don't want to set off another coughing fit for you, Fiona. So thank you so much for your informative talk. It's been amazing, and I know a lot of people have written in to say thank you. So I hope you have a lovely evening, everyone. Thank you for coming along, and thanks again, Fiona, for joining us.
Pleasure. All the best, and thank you.
Thanks.